as I said, if you biopsy the new area of disease and it overexpresses the estrogen receptor and it's HER2 new negative, we know it's generally still responding to the estrogen pathway. And the standard of care, so what we do if we rebiopsy in a patient and a patient has estrogen receptor metastatic breast cancer, the standard of care is to give additional anti-estrogen. And we give the anti-estrogen therapy with a new class of drug called CDK4/6 inhibitors. And you may have heard of some of these drugs. One of them is called ribociclib, otherwise known as Kisqali. One of them is called abemaciclib, otherwise known as Verzenio. And another one's called palbociclib, which is also known as Ibrance. And we add these agents to anti-estrogen therapy. And cyclin-dependent kinase inhibitors, these CDK4/6 inhibitors, work by targeting the cell cycle. And the cell cycle goes through various phases. And these cyclin-dependent kinase inhibitors halt the cell cycle, leading to arrest of breast cancer cell growth. And they're very important when added to anti-estrogen therapy. When they're added to anti-estrogen therapy, there's a whole bunch of clinical trials, at least 5 or 6 clinical trials, that show that the addition of the cyclin-dependent kinase inhibitors to standard anti-estrogen therapy significantly improves the time to progression. So on average, if you just treated ER-positive metastatic breast cancer with an anti-estrogen therapy alone, the time to which it would grow and you would need to change your therapy is about 13, 14 months. But you add one of these agents, or cyclin-dependent kinase inhibitors in the first-line setting, you double that and you take that out to about 24, 25 months. And when we look at these trials, overall survival approaches 5 years for patients in the first-line setting if they get an anti-estrogen therapy with a cyclin-dependent kinase inhibitor.